Okay. Hello everyone, my name is Frida. I'm one of the Clinical Genetics Fellow, and I'd like to thank Anne-Marie and everyone at Ovarian Cancer Australia for the opportunity to speak today about the genetics of ovarian cancer. Okay, so I'll just first of all like to say that as many of you would know, ovarian cancer is not one uniform disease. If we look at the pathology of ovarian cancer, there's many different histological subtypes of ovarian cancer, and the most common, accounting for up to 74% of all ovarian cancer, is the high-grade serous carcinoma of the ovaries. And I've listed on the right of the page the other histological subtypes that will account for the remainder of the ovarian cancer diagnosis. The second thing to say is that ovarian cancer is not a uniform disease when we think about the genetics. So not all subtypes of ovarian cancer are heritable. Now, we can divide up ovarian cancer into the epithelial ovarian cancer and the non-epithelial ovarian cancer. And epithelial ovarian cancers are those arising from the surface of the ovaries or from the surface of the fallopian tubes. And as you can see here on the left, the high-grade serous epithelial ovarian cancer, that's the one that we're most likely to identify a germline BRCA mutation. Kind of in that subgroup of ovarian cancer, that's the subgroup of ovarian cancer that we're most likely to be able to identify an inherited genetic cause to explain why that woman has developed ovarian cancer. So I'd just like to take a step back and just talk generally about genes and chromosomes. Now, typically there are 46 chromosomes in each cell, and they are grouped into 23 pairs. One member of each pair comes from our mum, and the other member of each pair comes from our father at the time of conception. The first 22 pairs are the same in both men and women and are not sex-specific. And the last two are the sex chromosomes, which in women is XX and in men is XY. Our chromosomes carry our genes, which are the stretches of DNA that has the instructions for how different parts of our body should function, how we should grow and develop. And we have approximately about 20,000 genes that help us do that. Now, besides the genes that's on the X and the Y chromosome, we have 2 copies of every gene. And I'd like to now explain what people mean when they say a mutation. So if you can see, when you pull apart a gene, what they look like is actually a series of base pairs, represented by an A, a T, a C, or a G. And how the base pairs line up next to each other is how the information is coded within a gene. Now, if we read all the genes of everyone in this audience today, we will all have slight variations in our DNA. And most of that is just what makes us unique and doesn't have any impact on our health. But sometimes there could be certain spelling mistakes that could affect the function of the gene, and that's what we call a mutation. Now let's quickly talk about the inheritance of ovarian cancer susceptibility genes. Now the majority of cancer susceptibility genes are inherited in an autosomal dominant manner. What that means is, as I mentioned before, we have 2 copies of every gene. And in conditions where the inheritance is dominant, having one abnormal copy of the gene or having a mutation in one copy of the gene is enough to give us the condition, even though the other copy of the gene is entirely normal. So what that means is when somebody has, for example, a BRCA1 gene, each time they have a child, there's a 50% risk that they could pass on the BRCA1 mutation to their child, and conversely, there's a 50% chance that they'll pass on a normal BRCA1 gene to their child. Okay, so as I mentioned in a few slides ago, there are many different genes in which mutations can mean that a person is predisposed to ovarian cancers. There's quite a lot of them, but for the interest of time, I'll talk about the BRCA1 and the BRCA2 gene first, and I'll talk about another group of genes in the next slide. So we all have 2 copies of the BRCA1 gene, and we all have 2 copies of the BRCA2 genes. And the normal function is to produce tumor suppressor proteins, the function of which is to help repair damaged DNA to ensure the stability of each cell's genetic material. Let me explain this in a little bit. So cell replication is an ongoing process, and it's not abnormal for us to accumulate little damages in our DNA as cell replication continues. Now, for a cell to go from a healthy cell to a cancerous cell, it's not obviously an overnight process. Lots of things need to go wrong at different time points. And the BRCA genes, along with other genes, their purpose is to act as tumor suppressors to fix any damages in the DNA that occurs to try and prevent the cell from occurring more mutations and eventually becoming cancerous. Now, the mutations in the BRCA1 and BRCA2 gene together occur in up to 20% of all women with ovarian cancer. So it's quite a common one. And it's definitely the two common genes that we test a lot in the clinical setting. And mutations in the BRCA1 and BRCA2 gene is not just associated with an increased risk of ovarian cancer, it's also associated with an increased risk of breast cancer. In men, it can cause prostate cancer. And primarily in BRCA2, people can also be predisposed to pancreatic cancer and skin melanoma. Now, it's also interesting to note that there are two specific mutations in the BRCA1 gene and one specific mutation in the BRCA2 gene that is more common in individuals of Ashkenazi Jewish heritage. Okay, so the next group of genes we'll talk about is the Lynch syndrome. Lynch syndrome is also another autosomal dominant condition that's caused by mutations in mismatch repair genes. And the mismatch repair genes are MLH1, MSH2, MSH6, or PMS2. Now, people with Lynch syndrome are at increased risk for not only ovarian cancer, but they're also at an increased risk for bowel cancer, certain cancers of the endometrium, stomach, small bowel, hepatobiliary tract, and also urinary tract cancer. It's interesting to note that the risk of ovarian cancer is highest in people with MLH1 and MSH2 mutation. And of note, when we look at the survival of women with ovarian cancer due to Lynch syndrome, they tend to do better than women with ovarian cancer due to a BRCA mutation. Okay, so I've talked about the kind of two big gene groups that we tend to test for when we see a woman with ovarian cancer. So how do we get in touch with these women and how do they access testing? So first of all, when we receive a referral at the Familial Cancer Center, or FCC, we will first of all usually send out a family history questionnaire and ask our patient to fill out as much information as they know about other members of the family who may be affected by cancers, whatever cancer that may be. And then we normally would routinely, if we have consent from the patient, verify the information that we have against records of a cancer registry. So for example, the Victorian Cancer Council has a record of all the cancers that's diagnosed in people in Victoria. And so we routinely will send our data across to them if we have consent from the patient, and then so we know which diagnoses are confirmed and which one are not confirmed. Because the truth is, it's very difficult. I mean, even though I work in genetics, I don't know what my aunts and uncles have, and definitely don't know what my great aunts and great uncles have. And once that information is processed, each family is triaged, and we do a risk assessment. Depending on the outcome of the risk assessment, we either offer them a face-to-face appointment or a phone appointment. And if the family is assessed at low risk, we will routinely just send a letter out to the patient with an invitation to contact us if they still have any questions. And so who's eligible for genetic testing? So women with most types of ovarian cancer are eligible for genetic testing, and they should discuss this with their doctor or a familial cancer center. Medicare-funded BRCA genetic testing has become available over the last 2 years or so, and it's available to all women with breast or ovarian cancer who have a 1 in 10 chance at least of carrying a gene mutation. How do we work out this 1 in 10 chance? So there's a few tools that we can use where we can put in the woman's diagnosis, we can put in the family history, and the tool will be able to help us to determine what is the probability that an individual carries a BRCA mutation. And there's obviously a few things that the tool will take into consideration. So age at the diagnosis is one, the specific type of cancer is another one, and also when families have people with male breast cancer, for example, obviously breast cancer is much less common in men, or when there are family members with bilateral breast cancer, or if the family is of Ashkenazi Jewish heritage, then those will confer a higher probability risk. And if the chance that a woman could carry a mutation is 10% or more, the woman would be eligible for genetic testing that's Medicare funded at no out-of-pocket cost. Sorry, what did I do? Sorry about that. Now, BRCA genetic testing is not funded by Medicare for women who are unaffected, so women who don't have a diagnosis of breast or ovarian cancer, unless a mutation is already known in the family. However, an FCC will assess each individual family, and each FCC will have additional testing criteria to allow greater access to more women. So, for example, all women with invasive high-grade serous ovarian cancer diagnosed at any age, even if the mutation probability is not 10%, can still have funded testing through the FCC. All women with invasive high-grade non-mucinous epithelial ovarian cancer is also eligible for genetic testing regardless of family history. And women with relapsed ovarian cancer, if the ovarian cancer is responsive to chemotherapy, will also be eligible for an FCC-funded genetic testing. And what's the gene testing that we do? We can either just test for the BRCA1 and BRCA2 gene, or we can do a multi-gene panel that tests BRCA1, BRCA2, the genes that cause Lynch syndrome, and other genes that we know can be associated with ovarian cancer. And which gene we choose depends really on the diagnosis of the ovarian cancer, at what age, and the family history. So generally, when women are diagnosed above the age of 60, in the absence of other family history, we'll just do BRCA1 and BRCA2. But if they were diagnosed at under 60 years old, we'll tend to do the bigger panel normally. Sorry, I keep losing the arrow. Okay. Now, over the last 1 to 2 years, we've also started mainstreaming genetic testing. So for patients who are eligible for Medicare-funded genetic testing, their oncologist or their surgeon can initiate genetic testing without waiting for us to see them in FCC. And obviously, if the mainstreaming results are positive, they will automatically be seen by us in the FCC. And this is a really good initiative for a few reasons. So I've got here the data from our FCC. In the first year after we started mainstreaming, 64 women underwent testing for BRCA1 and BRCA2, and we were able to detect a BRCA1 or a BRCA2 mutation in 17% of patients. The referral rate for eligible women significantly increased to over 90%, and the median time from the referral to the time when we give the result was extremely reasonable, less than 5 months. So we've been able to show that, first of all, mainstreaming is efficient for patients because they don't have to wait on the waiting list to see us in the FCC. Most of the time, they are able to receive their results when they are still receiving their first line of chemotherapy. So it's timely, and it's also efficient for genetic counselors and the cancer specialists who may want to use the results to guide the treatment options. So now let's talk about the benefits of genetic testing. So there are treatment implications to genetic testing. So for example, in some women who've been diagnosed with ovarian cancer and in whom we can identify that they carry a mutation in either a BRCA1 or BRCA2 gene, they may be eligible for newer treatments such as PARP inhibitors. This is a very new treatment that's very well tolerated. The side effects are not a lot. One of the more common side effects is myelodysplastic syndrome, where the bone marrow, becomes a little bit crappier and kind of the cell counts all lower a little bit. But besides that, one serious side effect is actually well tolerated without many side effects. Now, if we were able to identify women who carry a BRCA2 mutation, they're actually eligible for this treatment, which is more well tolerated than chemotherapy. The other benefit of genetic testing, if we found out that a woman carries a BRCA mutation, then that means that that woman is at high risk of developing breast cancer in the future as well. So we can then recommend breast screening that the woman might not have had if we found out that they carry a BRCA mutation. If we manage to find the mutation in the family, we will be able to test other relatives in the family. So when relatives wish to understand if they themselves are at risk of an ovarian cancer or breast cancer above the general population levels, they can then have testing. Genetic testing can also provide information for reproductive planning. So this day and age, we've got technologies such as pre-implantation genetic diagnosis. What this involves is IVF, and each embryo is tested to see which embryo carry the BRCA mutation and which embryos do not carry the BRCA mutation. And the whole idea is that we can then transfer selectively the embryos that don't have the mutation. So knowing the specific mutation in the family will allow couples to explore this option if that's something that they'd like to do. And then finally, another benefit is certain FCCs like ours offer a gene carrier review program where once a year we'll make contact, be it by letter or a phone call, just to check up on the patients and to see if there's anything else we can help with. Now, I've alluded to this before, but I just would like to cover this. As many of you know, unfortunately, there is no screening tool that's been found to be effective in detecting early stage ovarian cancer, either in the high risk or in the average risk women. So some of you may have heard about annual ultrasound of the ovaries and also measurement of tumor markers known as CA125. Now, there are a lot of studies that have shown that this in combination actually do not reliably detect ovarian cancers at an early stage and do not actually affect the outcomes of these women, both in the high-risk scenario and in the average risk scenario. So because of the lack of a good screening tool, so we don't have, unlike there's mammogram for breast cancer, there's colonoscopy for bowel cancer, because there's no screening tool, when we identify that women are at high risk of developing ovarian cancer, we actually recommend that they undergo surgery to remove both ovaries and both tubes when they've completed their family, of course. Now, this surgery would put the woman into menopause overnight. So we would typically refer our patients to the menopause clinic because hormone replacement therapy should be considered and is safe, to take from the time of surgery up until the time of natural menopause, which is about 50 years old. So we've talked a lot about genetic testing, what sort of genetic testing we can offer, and the many benefits of genetic testing. But unfortunately, genetic testing is not very straightforward, and there's a lot of things that one should take into account before consenting to genetic testing. So it's important to understand, obviously, the implications for the woman herself and also her family members. If a gene mutation is found, it may provide important information about future cancer risks and the need for ongoing screening or other interventions to manage this risk. However, it's also important to remember that most tests, when we do it, will come back with a negative result, so be normal. And the current testing analysis is very thorough. The genetic testing technology has come a long way. And if a result comes back as negative, it's unlikely that we've missed the mutation. But to no surprise, there is no test at this moment in time that can completely exclude that there is a genetic cause to explain the personal or family history of cancer. So even though the genetic testing is very good in that if you get a negative result, it does reduce the risk that the cancer is heritable. Unfortunately, if you get a negative result, we can't say for sure it's not genetic. Now, when we do genetic testing, sometimes we don't get a straightforward answer. So we don't get a negative or a positive answer, but instead we detect a variant of uncertain significance. A VUS is when we detect a spelling mistake, but we may not understand for sure whether that spelling mistake will affect the function of the gene and whether that spelling mistake can explain the individual's diagnosis of breast cancer. If we identify a VUS, it's a little bit obviously more difficult to get to the bottom of this because it's not enough to be positive, but it's not enough to be negative. And if that's the case, the family can work closely with us and we can try and examine this VUS a bit more and explain whether we should do any more testing or whether it looks benign enough that we don't need to worry about it. But yeah, it's important to realize that sometimes genetic test result is not straightforward. It's a little bit in the gray zone. Oops, sorry. And the other thing that patients very often ask me about is the insurance implications for themselves and their family members if they choose to have genetic testing. The first thing to say is that genetic testing will not affect the ability to obtain private health insurance. So when a person wants to get private health insurance, the insurance company is not allowed to ask if the individual has had genetic testing before. But when a person wants to apply for income protection, life insurance, critical illness insurance, in those instances, the insurance company may ask if an individual or a close family, like first-degree relatives, have had genetic testing done before. And if you say yes, the insurance company may then ask you to give them the result before they decide on your cover. So it doesn't affect existing policies, but sometimes we have encountered patients who've said, oh, look, let me sort out my insurance first before I have genetic testing, and that's entirely reasonable as well. And the last thing I want to say is that it's important to remember that having genetic testing is always optional, so nobody should be pressuring you to have genetic testing. And often we also see patients who say, oh, look, it all sounds very good, but I haven't given this a thought at all. Can I have some time to think about it? And that's entirely fine. And as my boss says, it's always better to be in that mindset than to just go jump ahead and have any regrets later on. So yeah, genetic testing is always optional. Okay, so I'd like to just spend the next few minutes to talk about Traceback, and I've had a few people ask me about this. So Traceback is a major cancer prevention initiative between the Peter MacCallum Cancer Centre and also Ovarian Cancer Australia. The aim of Traceback is to decrease the incidence of breast cancer and ovarian cancer in Australia by preventing those that are caused by inherited gene mutations such as BRCA1 or BRCA2. Now, this is the issue. So we think at the moment we are not testing everyone that we need to test. A significant proportion of people who should be tested are not tested at the moment. And out of those untested individuals, more than half of them would have passed away due to their disease. So the whole purpose of Traceback is to try and pick up these individuals who have missed testing because they've passed away or because the guidelines that allow for genetic testing has become more generous only recently. So there are definitely living patients who at the time would have been told no genetic testing for you, but would have been present if they were diagnosed today. So the idea of Traceback is to try and identify these women who missed out on testing and for women who's passed away who could have had testing. And what they do is they test the tumor block. They'll extract the DNA from a tumor block and test for BRCA1, BRCA2, and a range of other genes as well. And the whole idea is we hope that we can then capture these families with the mutations which we otherwise would have missed, offer predictive testing for their unaffected relatives, and by that way decrease the rate of inherited breast and ovarian cancer in Australia by putting in place a good preventative strategy. So I've covered a lot of this. So a woman, like a close relative, could actually refer a deceased relative to Traceback. Women who've missed out on testing, a lot of them would have been enrolled in certain studies. Through those studies, they could also access Traceback. And as I said, what Traceback does is extract the DNA from the tumor and perform testing on the tumor DNA. And the whole idea is we will return the results to these women or their close relatives. What's our progress today? Traceback is actually going really well. We've got a panel now that can report 10 genes, and we also have a research panel that tests for other genes which may not be as well established in their role in causing breast ovarian cancer, but we have the ability to test for these research genes. We've tested, and the technology that we have has been optimized and working quite well in testing tumor DNA. And we've tested more than 500 women, and we've detected quite a lot of mutations, and we're now in the process of returning the first batch of results. Okay, so that's the end of my talk. So this is some acknowledgements for the individuals who are part of the Traceback study, who've provided me with the Traceback slides. And I've got some references here for further reading as well.